All right. Well, good morning, everyone, and welcome to the Philips booth here at HIMSS 2017. We are just about to begin our first presentation of the day, and we have a great one for you. We're going to be doing a range of topics all week long at the top of the hour every time, or every hour, I should say. So please come on in and grab a spot. In just a moment, Dr. Carla Crevette, the CEO of Connected Care and Health Informatics here at Philips, will be here to introduce our first speaker, and we have some great information to share with you. There's actually a different topic happening. Welcome, gentlemen. We've got space there all week long, and you can get the topic list if you pick up one of them, the survey or the programs, that's the word I'm looking for, right over here on the desk. So if there's a particular area that might be of interest or a particular speaker you might want to see, this can give you all of the information that you need. And we do have a very distinguished lineup. Not only our senior leaders here at Philips, but also leaders from companies around the country, and also healthcare providers and well-known personalities in the business. So, welcome to Philips Connected Health Forum officially, and we can go ahead and get on. Once again, we're glad to have you here. And I'm going to be your host this week. Between now and Wednesday, as I said, we'll have exciting sessions with outstanding speakers on topics ranging from population health and care coordination and personal health to advanced analytics and clinical informatics. All take place right here in the forum, starting at the top of each hour. I'm pleased to announce that our first speaker is Dr. Kevin Delsberger, Chief Medical Officer at Augusta University Health and the Associate Dean for Clinical Affairs at the Medical College of Georgia. Dr. Delsberger will be discussing his vision for general care with biosensors and early warning scoring. And here to introduce Dr. Delsberger and to tell you a little more about the session is Dr. Carla Crevette, who is our CEO of Connected Care and Health Informatics here at Philips. So, Dr. Crevette.
Thank you. Thank you all. It's a pleasure to be here. Always great to be at HIMSS. And it's a special honor to have the chance to introduce Dr. Delsberger to you, because this gentleman is not just a great researcher. He's not just a great doctor as cardiologist in a leading institute of Augusta University Health, but he is an awesome innovator and entrepreneur. One of these rare partnerships where we really started very early on to go beyond transactions, to really already 4 or 5 years ago building a strategic partnership where we are sharing all the innovations in our roadmap and are co-creating the future of healthcare and the future of informatics. And with that, it's a great pleasure to introduce you and to ask Kevin Delsberger to the stage. Very much looking forward.
Thank you. Thank you.
There you go.
Good morning, everyone. How are you today? I want to share with you some of our journey as we've gone through our connected care as it pertains to our general units, not our ICUs, not the home space, but on our general care units where most of our patients sit in the hospital every day. This is a view of our hospital. It's a 520-bed hospital, of which 120 are children. We also have 40 operating room theaters. We have the ability to connect every one of our general care units to telemetry. That telemetry was put into place about 3 years ago as part of the early integration of our strategic alliance with Philips. We have a state-of-the-art telemetry suite, and we have the ability to start using Guardian, our early warning system, on 2 pilot units about 3 years ago. Why is this important? One of the key things we see in our root cause analysis and in our review of our arrests are there's an early deterioration of our patients. If you look back at the deterioration of our patients, typically it's somewhere between 4 and 6 hours before they actually have an adverse event or an arrest. That is plenty of time for someone to have recognized it. The problem with normal vital signs is I could be at the lower end of a range, move to the top end of the range, and most people think that's normal. On the other hand, I could be at the top end of a range and move to the lower, and it's still normal. But when you put them together, you actually see a trend that says these patients are worsening. And we need to do something sooner, or they're going to get into a point where we have to rescue them. We reviewed data on our renal transplant unit and our cardiology unit, and that's where we started this. We created a process improvement team. When we looked at a cause-effect diagram, we identified a number of issues that resulted in failure to recognize that this patient is deteriorating. This is a typical cause-effect diagram, and when we looked at drivers of that deterioration, we came up with these red drivers, and of those red drivers, we chose the 4 highest priority. We had a very low nurse-to-patient ratio. This is our general care areas. We had somewhere between 5 patients to 6 patients for 1 nurse. Secondly, we had issues with ongoing competencies. Like most of your hospitals, your new staff are the ones that are getting the night shifts on the general care areas. That's where you tend to be staffed the thinnest, and you also tend to have your least experience. We also had young physicians, interns, residents managing these patients, some of whom did not have the experience to see a trend line of deterioration. Third, we didn't use our escalation process very well, partly because our escalation requires these young nurses to feel comfortable calling an attending physician, one of the faculty. That's a very difficult thing for a nurse straight out of nursing school. And lastly, I don't know about you, but every time you walk around, you hear bing, 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 buzzers, alarms everywhere. I tell this story when I was in the CCU making rounds, one of my residents tapped me on the shoulder and said, "Dr. D, she's in ventricular tachycardia." I said, "No wonder I didn't hear the murmur. Get the crash cart." So part of it is you become immune to these noises in units. So the approach and method we took was we replaced all the spot check monitors with MP5SC with the Muse software in these 2 units. We installed the Philips Guardian solution on these 2 units, and we had a 27-bed unit, which was primarily renal transplant and postoperative GU, urology, and a 23-bed primarily cardiac unit. This was not the ICU, this was essentially the floor unit. We formed and implemented a new program for educating our staff about quality improvement and performance, and this was part of their project. And lastly, we had physicians review as to whether or not the codes we saw were preventable or not preventable. The not preventable codes were pretty easy. Patient doing fine suddenly had a ventricular arrhythmia, and that was a code that was not preventable. Or consequently, had a large saddle embolus that would not have been preventable. The nursing staffing was reviewed and adjusted per our chief nursing officer. We also had skill fairs introduced to teach people about Muse, but also teach them about general nursing competencies and recognizing deterioration.
One of the biggest things.
And lastly, another team was working simultaneously on alert and alarm fatigue.
And
We reduced by 60% the various alert and alarms by getting rid of a lot of our yellow alarms that no one ever took action with anyway. So we got rid of yellow parameter and yellow arrhythmia alarms. The escalation protocol was developed by the project team and approved by our medical executive committee, and we had 3 definitions. Routine issues, we expected a practitioner within 15 minutes. Urgent issues, we wanted the practitioner there within 10 minutes. And finally, emergent issues, immediately but not to exceed 5 minutes. If a practitioner didn't meet that timeline, it was automatically escalated to the higher level. Obviously, if you started with an emergent issue, you may or may not have gone through multiple levels. You would jump levels in order to get the patient taken care of. These are our results. So when I show you these results, this is the total codes on the Muse units. And the blue bars are before we implemented Muse, and the red bars are after we implemented Muse. So those are the codes per year. We had 1 year before we put it in place and 2 years after. The Muse predictable, these were the ones on the Muse units that were predictable. And then I broke them out into the various units. You can see we had one predictable code on 4 South and one predictable code on 6 South that we didn't catch, as opposed to before implementation 6 and 3. A striking reduction in our code rate. So we concluded that implementation of Guardian and this new process successfully reduced predictable codes by 89%. Overall, though, we saw codes reduce across the hospital. And you go, why would that be the case? We didn't put Muse there. But we taught every nurse issues related to competency of trying to recognize a deteriorating patient. So it's potentially a Hawthorne effect, but also it's an education in general that patients deteriorate at different rates. The escalation protocol was also house-wide. It wasn't only on those units, it was across the system. And then earlier identification of deterioration could reduce the predictable codes even more and perhaps even prevent codes altogether. Because if you intervene sooner, you're moving people to higher levels of care at an earlier point in time. And our next step was, how do we get more data? Right now, we were getting data every 4 hours. That was our normal on our general medical wards, a spot check every 4 hours. Then we learned in partnership with Philips about a biosensor. And I go, what's that? And the biosensor is the ability to measure on a continuous basis.
So that's one of the, on top of that.
So this is the wearable biosensor. It's essentially looks like a little dumbbell, and it's got adhesive on the back, and it's about this big. Very small, very comfortable to wear. It's soft rubber, and it transmits several pieces of information. It transfers heart rate, transfers respiratory rate. It also allows you to measure steps and position of the patient. So if the patient is laying down, you can see that. If they're sitting up, you can see it. But we focused on the vital signs, the heart rate and respiratory rate. Why respiratory rate? Well, respiratory rate, as the respiratory rate goes up, that tells you your body is sensing the need for more oxygen. If you were to exercise, you breathe deeper and faster. You do that because your body needs more oxygen in order to deliver that to the muscles that are exercising. Well, when you're sick, your body is under stress. It needs more oxygen. So small changes in respiratory rate can be profoundly important. And all of you who work at hospitals, if I were to measure your respiratory rate, it's 16, 18, or 20. And if you did a histogram, you would get huge spikes at 16, 18, and 20. I see a lot of heads going like this. We did the histogram. Yes, we had 16, 18, and 20. Then you had smattering throughout the rest. With the biosensor, you don't have 16, 18, or 20. You have more of a bell-shaped curve. That's because that's what people normally have, a bell-shaped curve of differences. This also is disturbance. I don't have to wake you up at 2 o'clock in the morning
Executive Medical
to throw a blood
Director.
pressure cuff, count your respirations, check your pulse.
U.S.
I can do that, not the blood pressure, but I can do the pulse And I can
Got
do
it.
the
Okay. Executive
respiratory
medical
rate
director informatics.
without
All
awakening you.
USC medical.
That's an important thing for rest, and we know people don't
Clinician.
sleep in a hospital.
What is driving the need?
And then lastly, this is single use.
Heading there. That kind of.
Patient goes home,
That's
you take
broad.
it off and throw it away. So as we collect the data, the patient has the biosensor on. It goes into a relay station, and that relay station is connected by Bluetooth to the biosensor and to the system through Wi-Fi. Then it goes to our EMR, event management system, and to the spot check monitor. So now, when the patient care tech goes around, the only thing they really need to get is the blood pressure. All the other data are coming from the biosensor. Now in our study, we're measuring the heart rate and blood pressure, or heart rate and respiratory rate as well.
Security blanket. So
And then, ultimately, we want this system to directly contact the bedside nurse. To alert that nurse that there's a problem with their patient so they can get in there and see it.
Orlando. Today I'm with Dr. Nick Patel. Nick is the
So
Executive
how does
Medical
this add
Director
value?
for Informatics
We
with
have a
USC
low
Pharma.
nurse-to-patient ratio and a lack of escalation process. We put the escalation process in place. We still have a low nurse-to-patient ratio. That's true pretty much throughout the
I'm
country.
Tara Buck, Tech
It helps
Magazine.
the
We're
nurse
at
keep an eye on the
2017 in
patient when
Orlando,
they're not in the room.
And I'm here with Nick
We know a lot about our
Patel,
patients in the
I should say.
ICU. They're typically one-to-one or one nurse to two patients.
All right.
I always worry about that second patient when that nurse is in that other
2017 in
room.
Orlando. I'm
That's
joined now
why
with Nick
EICU
Patel.
has been shown
Nick
to
is
be
the
so
Executive
helpful.
Medical Director
Because those are the eyes in the
Informatics.
sky looking at that
Health.
patient when they're not in the room. This is
Thank
the
you.
eye in the sky for those 5
Talking today
patients
about clinician
that a,
mobility.
that a
What's
nurse might
driving
have
the need?
6 when she's in the room with the 6.
So one of the biggest things that
Provides
deal
accurate
with,
and automated
unfortunately, we would like
measurement
health
of
records is
respiratory
about
rate.
that occurs.
It helps with
Unintended
alert and alarm
consequences
fatigue
of
because we can now use
technology.
trend-based
UC Davis has done a
multi-parameter
lot of studies
analysis
around this.
to risk stratify
A decline
patients.
in productivity of 25 to 33%. when
This
you're
is an
introducing
example of a
technology,
tracing from
especially
one of our
electronic health
patients.
records.
And what
a
you
lot
can
of that
see
driving force
is
is
we have
the check-in
the respiratory
time,
rate down
the
below,
login times,
and we have
the documentation.
the
Before,
heart rate in blue. And you can see we did a
very
spot check
seamlessly.
here,
Now it takes 2 to 3
spot
seconds
check
to log in,
there, and a
not
spot
only
check
for
there,
provider,
but we
but
missed
for the nurse.
this.
For mobility comes into play. Instead of using those,
So we missed that. That was in the evening. We know that patient got up and moved around. You can see the respiratory rate got up
to
too.
interact with that patient
We wouldn't have known
face to
that
face
without
instead of
asking.
back to the patient.
You wouldn't
It
get
also
that
gives you
spot
the
check. Now,
chance
what
to
if this were 2 o'clock in the morning
It's every visit.
and now the heart rate shoots up and the respiratory rate shoots up? That would be an alert to a nurse. Say something's wrong. That's how
Greater
you
mobility.
close the loop there.
That's
At this point, I want to thank you for your attention. Happy to answer any questions you may have.
Devices that we use, that
All right.
hospital.
Does anyone have any
provide-
questions for Dr. Delsberger?
And that they're secure. So we image our software.
Okay, we have one right here. Would you mind using this? We can hear you.
Yes, Dr. Ellsberg, thank you for sharing this very good results.
From
Is
other-
there also
Other security measures, such as security codes, fingerprint authentication, retinal authentication in place. Windows has Windows 11. HP has fingerprint authentication, and they're also getting Windows 11.
Whether or not the recovery is faster. Well, the surrogate would be length of stay. And yes, we're looking at length of stay, whether or not that's because they're sleeping better or we're recognizing deterioration and jumping on it much faster. I think it's probably the latter. The sleep doesn't hurt. Sleep doesn't hurt. At this point in the study, we're waking them up and still largely doing it as we can because we need to validate what we're doing.
It's really surpassed software.
Thanks for the question. Any others right now?
Make your
All right. Well, if you have any
Really,
questions, that you, oh, we have one more.
easier
Sorry.
for
Please
IT.
get that nice and close so we can hear you. Please.
Yeah, I'm very great results, and
instead of us having
my question
to
isn't really
secure
about
the device, they're
technology,
coming
but it's more
secure.
about the caregivers.
And the
It sounds
tablets
like there
becoming
was a lot of
faster,
change
lighter,
involved
bigger screens,
for
and the
the
battery
people
life
involved
is
in
very
providing-
important. That it
Could you talk
lasts
a bit
to do
about
a whole
that?
work
But
day
also,
is also improving
as
every
you've come
single year.
through it, what has been the impact on the caregivers?
Yeah, so the question is, there's a lot
Thank you
of
so much.
change that the caregivers had to undergo as we started going through this process. You're absolutely right. Our caregivers went through so much change, not
Thank you so
only
much.
with new technology coming into the hospital, but there was a total redesign of nursing workflow over the last 2 years. Some of that workflow enabled some of this work. Some of that workflow needed to be done anyway, regardless of this work. But the amount of change our nurses have had to undergo has been incredible, and it's also been an important component. Having these data has made the nurses more accepting of the change. When I showed them how many predictable codes we were able to prevent, those are lives. You can put a face on that. You know, it's not like it's some abstract publication in a journal. It's our hospital and it's our patients. So they actually saw this. They actually recognized people getting sick, called the rapid response team earlier than they otherwise would have. And our rapid response teams have actually gone up. You know, someone asked me, is that good or bad? I said, yes, it's good or bad. I'm not sure. I like never to call a rapid response team because I'd like to identify the issues long ahead of time. But on the other hand, I'd rather a rapid response team than a code. So the nurses are starting to adapt to it. And the big thing that we have to do to help them is get that on their task monitor. Their device that they carry to fire tasks, they've got to have that on their handheld. Because if they have to go to a central nursing station, it's not going to be the same.
Great question. Oh, one more question here. Absolutely.
Thank you, Dr. Delsberger. When you mentioned that you were able to decrease or eliminate yellow alarms, how much change management did that require with your risk management group to get that change accepted?
Well, we started off, there's nothing more powerful to a medical staff than data. So we actually brought data, I mean data, to them. And in our partnership, we had so much data, it wasn't even funny. We found out in 2 weeks we had 130,000 alarms in one unit. Not in the hospital, one unit. And when we broke them down by the type, we found out the biggest number were actually alarms that no one would ever act upon. You'd see 2 PVCs together, you get a yellow alarm. Anyone called me, I'd say, okay, thanks, hang up the phone. You'd see inoperable alarms. You know, the telemetry devices weren't working, the patches came off, there was a lead issue, the battery was dying, whatever the issue was. That was the biggest change management, because we had to teach people how to proactively deal with those so we could reduce them. And we reduced those by 50%. But there were a whole host. There were 6 arrhythmia alarms, and then we had some crazy thresholds in the ICU even for saturation. We had saturations in some of our order sets. Call house officer if saturation is below 93%. I've got people on a ventilator in the ICU, and they're going to call a house officer when the saturation is normal. So we got rid of those. We moved it down. So that's how we got rid of most of them. That all went through the various committees, the ICU committees, the cardiology committees, every major committee, and approved by the medical executive committee. And then there was a series. We actually did 5 or 6 of them at one time. All the arrhythmias went at one time. Broadcast email, socialized it with the entire group, and said, we're going live on this date. And then part of the reason we monitored all this code information was we were looking for issues that might cause problems. We had no events reported as a result of this. And then we had no events when we did the parameter alarms, largely the oxygen sat. Now in the pediatric world, oxygen saturation thresholds can be really difficult. And you can have a child who has a congenital heart defect, and they may run the saturation of 70. Well, what we're doing there is trying to train the docs, train the nurses, lower the threshold to a level that you're going to act on it. And that's a little more challenging because that takes a lot of knowledge of the underlying disorder.
All right. Well, thank you, Dr. Delsberger, so much. We appreciate you being here with us.
Thank you.
And thanks to all of you. Dr. Crevette, did you have any closing remarks?
Maybe just to say, as we learned, it's about technology, but it's very much about change management and great partnership. Thank you for that. Thank you. Thank you so much for coming.
All right. Thank you both very much.
you.
If you'd like to join the discussion, please tweet to us at Phillips Live and use the hashtag HIMS2017. We have another great presentation that'll be coming up here at noon, and that will be Partnering to Empower Connected Health with Alan Trefler, who is the founder and chairman and CEO of Pegasystems, as well as Jeroen Toss, Philips Chief Innovation and Strategy Officer. And please be sure that you get a copy of a program right over here where you can see all of the topics and speakers. We go at the top of the hour all week long. Thanks, everybody.